Thanks, Kelly. And thanks everyone for coming this morning. So I'm looking forward to sharing a little bit about what I've learned along the way and opening up, hopefully in the end, we can have an opportunity for some conversation, whether it's on the chat or folks are willing to unmute. I'd love to hear sort of thoughts and conversation as we move along. So thank you for welcoming us to the territory where you're at, and I'll situate myself as well. So I am joining today virtually in this space from Kamloops, where I work here at Thompson Rivers University. And our campuses here are located on the traditional lands of the Tecumseh to Secwepemc, part of Secwepemc Ulu. And these lands are unceded territory, and we do not have a treaty, as many folks in this province. So just recognizing the relationship and responsibility we have to the people here, the First Peoples of these lands. So as Kelly mentioned, this is, I'm sharing this as part of my dissertation research, and Dr. Kelly Stadjahar was on my committee, as is Dr. Susan Duncan, who is here today, and also Dr. Tanya Jacobek, and just acknowledgements to the team, because as anybody knows, this work is always done in a collective. And this was part of a larger project grant that we'll talk about that Kelly's team was engaged with. So I thought what I would share is just a little bit about the background of how I came to this work and sort of what led to some of the questions around home care nursing work in particular. I'll do a little bit of an introduction to sort of the approach that I used for the research, and then really spend most of our time talking about the findings and implications. And again, just an opportunity for us to talk about some recommendations and some time for questions and discussion. So as we get started, I'm always curious to understand who's here and your connection to this work. So I've put in a few Mentimeter questions. I'm not sure, I said to Kelly, I'm not sure how well this will work, so we'll give it a try. And if it works, fabulous, and if not, we'll carry on. So if you're able to scan the QR code, I believe you should then be able to answer a couple of quick questions, just getting to know each other as we get started. If the QR code doesn't work for you, you can use the website, which is www.menti.com, and the code is posted there. Now, it looks like my QR code's hiding the responses, so I may have to hide the joining instructions. There we go. Super. Okay. So most of us are here in British Columbia, and a few folks from Alberta. So welcome. The Western provinces are representing today. And this one might be a little trickier. I've tried to put in some categories, but if some of this doesn't fit, please feel free to pop in the chat. Just a little bit of what is your connection to home care? And you might be more than one. So there's options to answer more than one too, because we're never just one piece of the puzzle, right? Okay, wonderful, thank you. And I hope this, I'll be curious for those of you who are in the care provision world, if this fits for you, and to hear your reactions as we go along. So thank you for being here today. I know time is tight. So that helps, thank you. You know, when I'm looking at faces, it's hard to know who's here. So that just, I really appreciate getting a chance to, a little bit of information about who's here. So in terms of how I got started in this work, as Kelly mentioned, I am a nurse educator here at Thompson Rivers University, and my background is in community health nursing practice, primarily in public health, but then also working with Indigenous communities and providing practice support roles before I came to teaching. And one of the things I've always been curious about, and this kind of sparked some conversation with both Susan and Kelly, was the presence of nursing in our conversations about healthcare and about health and the work that's happening, and sometimes the absence of nurses in those dialogues. So I was very fortunate in my first year of my PhD to be able to join this research fellowship with Kelly and Damien, and the study that's the broader piece looking called Tackling the Home Care Challenge, which is across Canada, national study with a few different components. And so I was able to join and learn alongside with this team, and then ask some specific questions myself for my own work around nursing. And so, in terms of home care, some might say, well, why would you look at home care, and sort of why now and why nursing? And so I have lots of good thoughts about why it's important, and I'm sure you all will have your own thoughts about this too. And certainly there's a growing need for home care that we see talked about and that has been in the conversation for many years in terms of closer to home, which started in the 90s. And still now we talk about the need to have more home care services. And yet there's very little evidence in Canada about the work of nurses in that role. And nurses are the largest group of professional care providers in home care. There was also, at the same time as we were just starting these conversations, and I was starting to look a little bit at this, there was a flurry of activity in the news about the development of new programs for home care, meeting gaps, which were certainly there and are still there, and really looking at new programs to prevent hospital admissions and meet needs that weren't being met. But what was interesting about these is they were profiling nonprofit agencies and often paramedicine and different care providers that were helping to meet these unmet needs. But again, nursing wasn't profiled or present in those conversations. So it just led me to some questions around like, what's happening here? And it fit really well with the work that was happening with the larger study. So in terms of what was known a little bit from the context, so taking a look at the literature, there certainly is, and this isn't a surprise, increasing needs and increasing complexity in home care. In 2021, they said about more than 6% of Canadian households were receiving some kind of home care service, and that works out to be about 921,700 households. So when you look, that's a lot of people that are receiving home care services in Canada. Home is also identified a lot in the literature in terms of preferred location of care. So lots of folks talk about how they want to age at home, how they want to die at home, how they want to receive care at home. So that is a discourse that certainly is in the literature. It's also adds some complexity in terms of unseen work. Because of the private nature of homes, often the work that's done then is not as public as in public institutions. There's also a lot of conversation in the literature about how home care is positioned within the healthcare system in Canada, because healthcare is, funded through the Canada Health Act in terms of the provisions of what's each of the provinces and territories is required to fund and provide. There are some unique features with home care because it's not included in that medically necessary biomedical focused Canada Health Act. So there's actually 13 really different systems of home care across the country, which adds to the diversity and complexity of home care. And then lots of great conversation coming out as well, particularly from our European colleagues around the managerial turn in home care and the focus on saving money, not enough money, the idea that we need to increase our focus on tasks, and the reality that there's time constraints, as well as the system is there to supplement, therefore an increased reliance on caregivers. So all of these pieces hopefully sound familiar. They're certainly present in the literature, and lots of good conversations sort of happening around those pieces. And again, left some opportunity for me to look at then, so what does this mean for nursing, and how does this influence nurses' work? So a little bit about sort of what I came to look at then is within this larger framework of the Tackling the Home Care Challenge project, I focused in on nurses in one health authority here in British Columbia to understand a couple of pieces. One, how do the nurses describe their work? And the second piece is looking at the ruling relations, or what are the things that are really coordinating and influencing the day-to-day work of nurses? So policies, processes, structures that are impacting nurses' work. And by looking at those, that allows us then to look at opportunities for change. And so those are sort of the two broad research questions. And I did use institutional ethnography as my approach to research. And why that matters is because it informed sort of the data that I collected and how to look at the data, and also through whose lens. And so in this case, it is grounded in this, belief and understanding that the work that is done, the everyday work, the day and night work, as Dorothy Smith calls it, is organized socially. And that if we look at the text and the processes that people are doing, we can come to understand those larger influences. And so from the standpoint, and the standpoint I chose was nurses, what is that everyday work? And how do we come to understand those larger influences by pulling the threads and analyzing out through the language and policy? And so the reason I think this works really well for this kind of inquiry is it does connect us to those larger pieces of policy and creates opportunity for us to look at how do we shake up some change and what that might look like. So in terms of a little bit of context, we started data collection during the COVID-19 pandemic. And so as we had, a plan, we had to shift and change a little bit with that. And so we did do a number of interviews over Skype, or I guess we used Zoom. And then we were able to access sites to do some observation and also collect texts. At the same time that we were starting this work, just before the health authority had implemented a new electronic health records and documentation system for the home care. So it had been previously used in other locations within the health authority, but this was just starting in home care. So I used data because the project was collecting data from a number of sites. So I used it specifically from BC, and I looked at 4 health units. So one was in a smaller community and 3 health units that were located in a larger community. The participants I looked at were nurses, so 10 nurses altogether. 7 were registered nurses and 3 were licensed practical nurses. And second level participants, so the folks that I connected with after initial data collection and analysis, were 3 registered nurses, and they happen to all have leadership roles within home care. So I looked at the interview data, and there was just such rich descriptions. You'll see some of those as we get going, and observation, which I felt really helped me to see the words come alive, and really helped in terms of the data, the data collection and the research approach, helped me not verify, but helped to really see what the people had said in their interviews come alive. It was really reaffirming. And then I also collected texts, because a large part of institutional ethnography and that tracing up into the larger understanding of the influences is very pragmatic and is very linked to the text and the language. And so we collected texts as well that were used in the day-to-day work of nurses. So the analysis process is very iterative. There's a lot of listening, a mapping that I'll show you, and then also just tracing those pieces and that language from the day-to-day work into the larger frames and policies. And so I was able to meet with our Tackling the Home Care Challenge research team, as well as my dissertation committee. And there's also some institutional ethnography networks that I met and shared ideas with as I was doing this work, that really helped to kind of guide and influence sort of some of the conversations and how to come to the data results section. So using the observations and the interviews and the texts, we started to understand a little bit about both how nurses describe their work and also some of the influences on their work. And all of this was done coming from and coming back to the viewpoint of nurses. And so I know this is a lot of text, but I'll just share a few highlights of how some of the nurses described their work. And from the rich descriptions that the nurses gave, they just really talked about the rhythm of their day. And they spoke so clearly about their relational work and the connections they had to clients, the unique autonomy that they have in their practice, as well as the challenges that can create sometimes. The work that is done to coordinate care for clients and families, including referrals and documentation, the support that's given to caregivers, and the decisions that are made around what care to give in that moment, but also determining next visits and who needs to know information that they experience and encounter on their visits. There's the work about collecting supplies and moving from home to home in terms of traveling and mapping that out. And communication that just happens, from the day the time you start your day till the time you leave. So a couple of pieces that some of the folks shared, and these are all pseudonyms. But Bob spoke to this piece about what it's like to move in and out of people's homes, and the work sometimes. And what I appreciated about this was the work that is sometimes unseen. So you're bouncing between all these different people and their different care needs. And like, I think there's a lot of empathetic burnout in the community because we're just yo-yoed around, like with each client. It would be like a float nurse in the hospital running from around the floor each hour kind of thing, like going from renal to cancer to end of life every single hour. It's like you get exhausted. And so I think he really spoke to that piece of the emotional work and the sometimes unseen work that nurses are engaged in when they are moving in and out of different situations and different care needs. And the second piece, he spoke so clearly about the importance of that connection and relationship, but also what it's like to move in and out of people's lives in a very intimate way as nurses. So Bob says, you know, going into people's homes and seeing their family photos on the wall, seeing how they decorate their homes, seeing the people they love and who support them, and just being privy to their life at such a vulnerable stage. It's very rewarding, but it's also exhausting. And it's so hard not to take some of that stuff home with you because you see some people in like a really, really challenging situations and you're so immersed in their life. It's hard to kind of jump back out of that. So that's the struggle I'm working through as a community nurse. And I think some of the others spoke to the piece of diversity of practice. So this idea that we're a jack of all trades that Kim speaks to in this quote. And also this piece about the difference of being in a home. And so Anne spoke about, you know, just going out and seeing what a home visit looks like. And, you know, for wound care, it's not just a wound care, right? So it's the whole thing, the big picture. And it's just getting used to that. It's community nursing. It's out of a lot of people's comfort zones, right? You're going to go into someone's house, so you're on their turf, and it's a little different. And several of them spoke about that piece of gaining consent to go into homes and how it's different in a home care environment than it may be in other nursing settings where you have assumed consent and you might, you know, march into a room and introduce yourself, and that's very different than arriving on someone's doorstep. And I included this last one from Ray because this one really helps to see how sometimes institutional language and influences is taken up by nurses. And so Ray says the purpose is for home care to keep them healthy at home or manage them when they've been discharged and to support clients in different ways at home so that we can, in a perfect world, keep them out of the hospital system. And so that was one of the things we'd asked about was, you know, what is the role of home care? And so it's just really interesting to hear some of those very, you know, very specific institutional sort of conversations about what home care is. And as I put this together and sort of, you know, reflected and was doing some of the analysis, it was really clear that from the moment the nurses arrive and swipe their key slab on the door to get in and gain access to the, you know, the last fax they sent, their work is institutionally influenced. So there's a reason and a purpose and a policy behind almost everything that's done. And to try and track that is really very interesting and challenging. So as I listened and learned and sort of observed, I started to hear some of those influences in the language starts to come clear. And what it led me to do was to focus on a specific document as a problematic. So that became the focus of the analysis. And it was the itinerary document. And the itinerary document is really, it's an 8x11 sheet of paper where the nurses put their client list each day, and then they complete a checklist of what kind of visit they're completing, and they transcribe a safety score onto it. And then there's little spots that, you know, varieties of different notes, and nurses use it differently in terms of the notes they kind of put on that. But in looking at this itinerary tool, it really started to reveal a lot of the influences on practice. And so I'm going to show you next one of the examples of a map of looking then at what is the work that was done to create this itinerary tool every day. And every nurse spoke about it. And this was in everybody's everyday work. And so at the end of the day, really what they're trying to create is this form that helps them to organize their day. And also is used to create data for the health authority around how many visits are completed and by who. So in order to fill out your form, there's quite a lot of work here that gets done. So as you can see, these blue boxes are all different documentation systems or documents that the nurses access to help understand who their client is that day and to then put that little sticky of the client they're going to see onto the itinerary form. But the information that's collected from this is critical, right? Who are they? What are they needing service for? What was the last time they were seen? What are the supplies I'm going to need? All of the information that's needed in order to go out and complete the visit. In this case, there were over 3 to 5 documentation systems that would be accessed electronically. And then there was also paper charts still in this setting that was used. And the nurses recorded their safety scores and the types of visits, and this created sort of this count, right, of how many clients they were seeing that day. So this was sort of the information that nurses could see and that they did. At the end of the day, their form went to the clerical staff, and then they actually input the numbers back into another data system that then created reports about the number of clients that were seen. So I put a little, it's kind of faint, but this little blue line here. Sometimes what isn't seen by nurses is what's happening above the line. And this is where we start to look at tracing and understanding these influences of policy. So the WorkSafe policy was directly linked to these safety scores in terms of even the language it was used in the policy was directly the same in terms of risk mitigation and those types of things. There's guidelines on what is a visit from the Ministry of Health that defined very clearly what you could count and not count as your work. And then there's also these pieces about how the reports were being used and generated from the health authority that often the nurses didn't see or didn't know about. It was interesting because the second level participants, the nurse managers, were very clear about how the data was used, but the nurses sometimes weren't in terms of how that data was used. So it was interesting as you started to pull apart these pieces of work to see how this coordination of their work was happening. And I've put this one in, it's very long, and it's from Bob again. But the point of this is that this was his description of this circus in the morning, of what it was like to pull all this information together to determine really who you were going to go see. And so he speaks to how we flip through, our district binder, and then we take a look at our computer and we match it up on the calendar, and then I have to get their actual charts, and then I might need to phone the doctor. And then I need to look at their safety awareness to make sure, if they're violent or if there's pets in the home, we've addressed that. And then, you have to remember that not everybody lives like us. And so then he needs to gather his equipment and needs to decide if he's going to delegate care. And sometimes there might be a float nurse and they could do handover. And then you need to huddle with everyone and just get a chance to see who's doing what. And then, you get all that information. And he says, it's really a circus. The first hour is just figuring out who you're going to do because you're going back and forth. And now this person's going to be a longer visit. So now I have to juggle my schedule to see who I can take instead of them and trade them off. And well, they're in that neighborhood and I'm going to this neighborhood. And how do we figure that out? And so it's just the logistics, right, of all of these pieces of figuring out who we're going to see and how we're going to make sure the right person's getting to where they need to go. All of that is done, and none of that is recorded on that count of daily work, which we'll speak about. So this is a little diagram that I've used that comes from sort of the institutional ethnography way of thinking about things that I kind of like because it helps us to kind of put it all together in a picture. And this is something that Dorothy Smith calls the small nurse hero. So the idea is we have our nurse here entering into this first line, which is really the work that they're doing and seeing. So they're completing their itinerary sheet to get organized and get their clients ready for the day. They're completing their safety assessment and planning. And that's their world of work, right, that needs to get done. And when we look up a little bit into the language of that and start to look at some of the documentation, we see the documentation identifies risk scores for safety and is counting the types of visits. And then when we understand, well, where does that come from? We move up into the next layer, which is the policy. And as I mentioned, it was so interesting to sort of pull on these threads and look because it was really evident that the language is congruent between this policy right into the documents telling the nurses how to do this work. And then it brings us up into these larger sort of influences and these larger sort of organizational documents and sort of philosophies around the importance of data and measurement and understanding some of these pieces that are really controlling and influencing this next level of policy. So when we completed the analysis, or when I started to look at sort of what were some of these main ruling relations, these main influences on nursing practice, it came down to a few of these pieces, which was safety, efficiency, the need to objectify or measure nursing work. And then there was also a bucket for me when I was looking at this analysis about what's missing from all of this. So I'll speak to each of these and provide some examples as we move along, but these were sort of the higher level summary in terms of the safety discourse and how nurses are accountable through that on their itinerary form and their documentation. The efficiency focus around the focus on needing to plan and be accountable for our resources and the idea of rationing care. And then the piece about measurement, really looking at what is counted, what is seen by by the health authority, and how that measurement of work is just really abstract from its account, right, a ticky box, and how that is influenced by sort of larger systems values. And then really there's a lot that's missing, but some of the pieces that came clear were that the work that nurses do to balance all of the needs that clients have and the health authority needs, as well as the coordination and organizing work, and the true cost of home care. Check my time here, we're good. Okay, so this is a safety piece, and I found this one so interesting because this was really clear that this was an institutional influence. The language, as I mentioned, was straight out of the WorkSafe policy. And so when the nurses talked about this, one of them said, the itinerary sheet's used by administration to make sure they know where we are. If we don't end up coming back, they can see around what time we were going somewhere. It shows the risk level, and if it's a 2 or 3, we have to call admin and let them know we're safe. And so if it's a 3, we just say our estimated time, and then we call them or they call us. And if it's a level 4, there's a different process. And so they're very clear about how to use the itinerary sheet. And then Jen says, it's a bit funny because it says for a medium or high risk to ensure that the designated work alone clerk is advised. So you check in with them a bit more. I don't know how much that function is used, because if it really is that dangerous, you'd think you'd have a 2-person visit. But I was just telling my partner the other day that I think home care nurses, we do experience a bit of sexualized violence. Maybe like a lot of time it's just more than I think it is. Like we mitigate those things more with behavioral care plans. So despite the fact that there's this system for recording safety scores, for assessing safety, and for transcribing it from the electronic record onto your paper record every day, there's still some real gaps in nurses feeling safe in their care, and some questions around how that could be changed. The last quote I've put in here is from Ruth, who talks about a situation on a visit where she arrived and the safety score was one thing, which is sort of low risk. But when she arrived, there was actually more risk than had been reflected. And it obviously changed. And she got into a situation that was rather uncomfortable for her. And she said, when I left and got back to the office, I updated the score. He gets home support. So I sent the home supports that score as well and updated them. And then I came home and thought, it's been a long time. I need to take martial arts again. So I signed up for martial arts. And this was a nurse who spoke quite clearly about how safety oriented she was and how she planned for safety a lot. And she left that situation feeling very unsafe, and that she needed to prepare herself differently so that she can enter into a home and feel that she had the skills to protect herself. So there's certainly coordination and influence of safety directly into the practice, and an opportunity, I think, for some change around what some of the work that's done to actually support nurses to feel safe in their practice. And while we talk about sort of the work safe piece around working alone, which is a lot of where this policy comes from, there's also a piece of safety that's missing. And so Bob talks about, this piece about being alone in a home to provide care, and how that can make you feel both sort of vulnerable and potentially psychologically unsafe at times, right? So one of the hardest parts of this job is you go there and you don't have any buttons at your side. You don't have staff to help you out. You're on your own. And so you're autonomous in your practice. And that is great, but it's also really scary. Like not having a computer, and not having the ability just to step outside, looking something up and then going back inside. You can really feel it. It can just be really terrifying. Like some of the really vulnerable patients, and not being able to just quickly work with them. So there's this piece, I think, that you just described so well in terms of that autonomous practice is, a real strength of home care that's recognized and understood. And then there's also a piece of support and challenge that can come with this. And so sometimes these safety scores and the way that it is evaluated and measured isn't comprehensive in its view of what safety is for nurses. So one of these other main sort of recognition of ruling relations that came through was around efficiency. And so this was something one of the nurses, Jen, said, I'm always playing around with how I can be just a little more calm throughout my day because I definitely feel this pressure of myself racing the clock. And I don't like that. There's definitely quite a few days where I just think to myself, I could have done that better if I wasn't rationing. Like, this is a really simple thing that I missed, that if I just felt like I had time to read the full email or do this research, I would have been a lot more efficient. Or, all of the tasks they want me to complete, I would have noticed. I'm trying to stay calm in the morning, but often the morning before I leave the office is kind of racing the clock. Because if you get out of the office early, you normally feel like you have a bit more space in the day. And so she actually uses these words of rationing and task and efficiency directly in her description of how she was feeling about the organization of her day. And so there's this real sense, I think, for nurses when we looked at this around the need to do more and do more often with less. The sort of piece about home care saves money for the system comes into play with this as well, in terms of nurses often feeling that they shouldn't be costing the system. Home care should be saving money. So that discourse around how and where home care fits into the healthcare system comes into this as well. And really, when you look at the itinerary form, what is counted is the number of visits completed on the day. And so that does create a sense of, I need to do more and I need to make sure that I'm meeting, expectations. Although there was no documented expectation of the number of visits of her day, there's an inherent sense, right, that comes with it. So alongside that, and I found these ones harder, pardon me, more difficult to tease out, was this, but it was very clear how nurses' work was being counted and measured. So what was interesting was that when we talked about the itinerary form, several of the nurses understood it to be sort of, this place to record and keep track of who they were seeing, that they handed it in at the end of the day. But some of them didn't even really know why they gave it to the clerks at the end of the day. So Jen says, on the copy of the itinerary that's left at the office, I'll input the time of the visit, and the admin keeps it. And I'm pretty sure they put the demographics into some system for health statistics or something. And another one spoke similarly about that. I think they keep it for legal reasons. So it was interesting that the nurses weren't really sure. Some of them had a sense that it was to count and to keep track. But when I spoke to the second level participants, and this Tara, who's quoted the next two, is one of the second level participants who was a leader, they were very clear and very articulate about how that information was used. And so the itinerary form is a way to collect this data, the number of visits, and our admin enters it into the system so that we know how many face-to-face or remote visits were done. I actually don't think it's super accurate. And the way we track data, the remote visits, I think anytime you're working on a client, you should be tracking their data, not just if you had a 10-minute conversation with them, but now you need to do 2 hours of paperwork. The 2 hours of paperwork, I feel, should be documented as a visit. I just think we need to note that this data isn't all the information you need to look at. There's driving time and geographic areas and gas mileage and all of that sort of stuff. And she went on to talk about a little bit more, saying, how are we capturing the data then? And that really is where funding all of this is coming from. They want to see the numbers, right? The number of clients, and that's another piece. They're not looking at the complexity of the client. Like the clinician could have 50 clients on their caseload, but maybe 3 of them need to be seen every single day. And that's 3 people of your caseload that you're seeing every single day. Where another clinician might have a few more on their caseload and a ton of them. You're only going to do once a month phone call check-ins with. So that's where it doesn't take into account the complexity of clients that you're seeing. It just doesn't take into account the straight numbers that you have on your caseload. So there's this reality of the turn in healthcare and in home care that was really clear about the need for data and the need for numbers and the nominalization of care down into these check boxes of, was it a visit or not? And the policy from the Ministry of Health very clearly defined what you can count and what you cannot count as a visit. And so some of the work that Tara was describing around coordination and documentation, the paperwork, some of the visits that you might just going to drop off paperwork, you can't count even though they are work and even though they are time. And so there's a pressure, right, on nursing staff because they are being monitored and they are being counted. And I think there's also an interesting question there about how the data is mined without staff knowing sometimes what that is being used for. So when we look at this, there's a lot that is missing from the itinerary sheet and from the work and from how it's being represented up to the institution, in this case, the health authority. So all of this organizing work, all of the prep work to get that itinerary sheet done, and then all of the end of the day work, the referrals, the conversations, the filling out forms to get equipment for folks, connecting with the pharmacy, printing off sheets so they can fax to the doctor, and then to receive the fax back and put it back in the computer. All of that work that's done to coordinate care isn't captured a lot of times when in the counts of work. So this is again Bob saying, just sorting out can be quite a struggle. But essentially, I could get to work a half an hour early because we get a lot of emails, and of course with COVID and stuff. So I do try to keep up to date with my emails, and we get emails from home support that say care plans need to be changed on the home support side. And so we have a feat on a lot of different buckets, and a lot of responsibility does fall on the district nurses. So I could spend a whole day not seeing anybody, but physically working and physically using my nursing skills and assessments and stuff that don't actually get, seeing clients. So there's a lot of extra work that gets done by nurses. And there was also this conversation that came up, and this was again from the nurses' discussion about the value of home visits. And this is something again that, although it is recorded in terms of home visits versus remote visits, there is a sense that there's a tension between this efficiency focus on if clients are mobile, as soon as they're ambulatory, they should be coming to us in clinic settings. And then only the folks that can't get out and about get home visits. And this discussion and definition was being clarified and was becoming much more of a push to have more and more clients come in to the clinic. So nurses spoke quite clearly about what they see as the value of home visits and the richness of that connection with clients when you're in their home. And so Ruth provided this example of walking into a home, and she said, you can tell if they're diabetic, you can tell, and they're drinking a small cans of diet pop, which he was, or do they have a full case of sugary soda at the front door? You can tell if they're having a hard time letting go of things, and maybe their mobility has changed and they have a lot of clutter in their home, but it's simply because they can't get out to remove it. Sometimes it's because they can't deal with parting with it. So it's just another one of those pieces that you'd never see in the hospital, or how an actual person functions, where they keep their medicine, if it's organized, or if there's medicines in every single room of the house, which sometimes you find there's medicine in the bedroom, in the bathroom, the kitchen, the living room. And I'm like, how are you managing this? So speaking to that piece around how valuable it is to see and to be in this space with people in their own homes. And the nurse Pat here spoke about how important it is to do teaching in the home as well. So she gave the example of teaching somebody with a new ostomy. And we could do it in the clinic, but really that's not where they're going to be doing it. So it's better to teach them in their home where, like she said, these people are going to be standing in their bathroom at their bathroom counter, and they need to have all their supplies ready, and they're going to be using their own mirror to help them see their stoma and clean it and put the new appliance on. So it's almost better in those cases, even though many of them may be well enough to come to our clinic. It doesn't provide that setting, that kind of need to set their comfort level and just do it in a way they're always going to do it. So they were very passionate about sharing those important pieces around the value of home visits. And this is the last piece I'm just going to mention is this came very clear, the coordinating role and influence of documentation. And so it was a unique time, as I mentioned, they were just transitioning. So there's some pieces of paper documentation that still existed and some things that were still being worked out. But documentation certainly coordinated the work that was happening. And then also, as you've seen, reflects what was being shared in terms of understanding. So the first quote was from one of the nurses who talked about how they had been asked initially to document in the home using computers on their laptops and using the new electronic documentation system in the homes. And she said, it isn't a practice that anyone's adopted or anyone's really comfortable doing it. It's uncomfortable sitting in people's homes, setting up on a computer and, trying to work out technical difficulties and then just sitting there and charting. And it's very personable as well, especially during those palliative visits. You're trying to connect with people and be attentive while trying to fiddle with the screen at the same time. And the kind of alternative was to chart in your car directly following the visit, but it's not always ergonomic. A laptop in your driver's seat, trying to position yourself in a way to properly type on a laptop in your car after you spend 5 minutes hooking up to your hotspot, connecting, pulling everything up, logging into your hotspot, it's not comfortable. So this piece of sort of the projected sense of what we're going to do with documentation versus the reality of what was happening. Many of them spoke, this wasn't realistic to document using your laptop in the homes. There's also some comments about how there were the workarounds. So, this comment from Jen that the supply lists are never up to date. So I don't rely on them. Invariably, they don't have the right things. So I do a lot more digging and over preparedness. And so we also put stickies on the label of supplies. And I think people are really overcompensating to make sure things don't get missed. So the use of sticky notes and extra notes was happening quite a bit to ensure that they had what they needed because the documentation system wasn't supporting them. And then Sandy spoke to this piece about what we're capturing and not capturing on documentation anymore in terms of it's hard and people are not pigeonholes. They're not ticky boxes, You go see a client and you can end up there for 3 hours because they're crashing palliative or their caregiver is crying and you can't leave them alone. It's that kind of thing. How do you measure something like that? It's impossible. So this piece, again, recognizing the gaps in what is captured in the data. And so there was lots of opportunities for us to think about how to create change. And, it's important for us to look at, and, what I appreciated about this was the ability to see and uncover some of those ruling relations, but that doesn't create change on itself, right? So it's important to name it. And then for us to look at what do we do with, opportunities for change and creating some of these. And so understanding the roles and the work of nursing practice is essential. And it's important for us to talk and document and continue to share because there is so little information out there about the very complex and deep work that nurses are doing in home care settings. The visibility and advocacy in terms of representing that work is so essential, and recognizing again that a lot of what is collected and reported out isn't contextualizing the work of nurses. In terms of information systems, there's a reality that they're being used and recognizing sort of that influence of counting and managerial turns, but also there's a need to make them better and to make them represent nursing work and to also have them so they're usable in terms of supporting the work of nurses. And so having nurses involved in systems development and having nurses involved in that provincial and national engagement around electronic, documentation strategies is essential in terms of that understanding and nurses' perspective, the day-to-day work. In this case, too, there's also an opportunity through the information system sort of lens to look at the safety audit piece and how nurses are using that and to create systems that are responsible and reflective of the work that they are doing and the need, again, to support their practice. And when we look at the policy pie, there's the local piece of policy around forms that can be changed and processes that nurses could have influence into, making more straightforward and supportive of their practice. There's also an opportunity to look at those provincial policies around what is defined as a visit and to look at really sort of, what are the opportunities for change around those definitions. And to really question sort of at a national level, how are we representing nursing work? And the policy around sort of the home care funding and standards of care and practice. And there's so much opportunity for continued research around home care nursing work, as well as looking at how do we support evaluation and representation beyond a cost measure and beyond a count, and really looking at the caregiver component. And there's some wonderful work happening in that, but this wasn't an area that I explored in my work. And there's also increasing conversation, I think, is around a need to understand what a nurses' workload looks like. And I hesitate to use the term workload, but it's sort of that piece of how do we support and look at what's reasonable for nurses to take on in an area, and the number of clients and the complexity, and how do we understand that a little bit better. A lot of the nurse managers talked about it's helpful to have this data, but I need to contextualize it. And so thankfully in this situation, they were able to do that. But in many health authorities, if there aren't nurse managers or leaders who can contextualize data, the information is very limited in terms of that. So I had one last Mentimeter here. I'm not sure, because I'm just curious if you have thoughts around opportunities for change, and things that we should be thinking about or questioning or pursuing in terms of creating change and making some of these systems that we've uncovered a little bit different or better for home care nurses and the work that they're doing. Oh, this is great. Thank you. Yeah, the streamlining documentation is it was mind-boggling to me to watch these 5 different systems and all these different places they would pull from. It's quite something. And yeah, the sense of where our values are and the mismatch potentially with the importance and value that we have on relationships and relational care with clients, and that clients and their families need. Yeah, and certainly that valuing of time is interesting. I think information systems is a whole piece that would be fascinating to really look at in terms of how can we streamline and really leverage. I mean, there's so much potential. It's mind-boggling that we're at this, I feel like sort of very early steps of what could be changed to make things better. Yeah, and exposing students to the opportunities for learning and understanding these practice areas would be wonderful. I was just saying to Kelly, I have some students right now in their spring practicums in home care, and after their first week, they were like, wow, I had no idea all of the work that happens behind the scenes. And an interesting thought that it was really task focused, and they were sort of blown away with all of the information and education and teaching that they were doing. It was really fun to see, but certainly an opportunity and a really important one for students to learn and to see, this true nursing work happening in a community setting. Yeah, and articulating practice, that would be I think something we just need to continue to really strive to do. And I was talking to these students actually, and I was saying, it's funny how we revert back to explaining the work we do often in tasks. And it's almost like that's the commodity to sort of explain what we're doing. So, I do dressing changes, or I, care for IVs, but really I'm a care coordinator and I'm working at, helping people to stay at home. And what does that mean? There's, a real opportunity for us to think about how do we talk about our work, and how do we talk about our work in different ways. Well, I hope it's not too dreary, because I do think there's lots of opportunity for change, but it can be a bit overwhelming too when we start to look at some of these larger pieces. And I love this suggestion to change our neoliberal ideologies. That would be an important piece, but a challenging one. Ideas are welcome for that. So yeah, I just wanted to say thank you for joining me today and for the time that you've given to sort of listen and to hear. And I've shared my information here if anybody wants to connect or learn any more. And I don't know if it's possible, if there's any other questions or conversation that we'd like to have either on the chat or in person. I'd welcome that now. So thank you.